Welcome back to our series of educational lectures. This presentation is about clavicle fractures. Clavicle fractures or collarbone fractures are very common traumatic injury. They account for 3 to 4% of all fractures. Often seen in young adults after fall onto shoulder or an outstretched arm. This is a very common injury with cyclists and with AFL footballers. Mid-shaft or middle third clavicle fractures are the most common type, accounting for up to 85% of all clavicle fractures. So that's where we'll start focusing our attention. Mid-shaft clavicle fractures diagnosis is often self-evident. You may see skin tenting, deformity and bruising as in the clinical picture, but often an X-ray is required for diagnosis. And I'll just jump straight into the management. So this is the landmark paper for surgical management of clavicle fractures. Historically, clavicle fractures are treated non-operatively with good outcomes. Landmark paper, which is this one in 2007 by the Canadian Orthopaedic Trauma Society, recommended surgical fixation in quotations, completely displaced mid-shaft clavicle fractures in active adult patients, end quotes. They showed that there was an improved functional outcome and lower rates of malunion and non-union. And as you can see from here, I've pulled out the functional outcomes that they're reporting on. So the constant shoulder score, which is a patient-reported outcome, showed a better improvement in shoulder function in the operative group compared to the non-operative group. Also, the DASH scores, which is a disabilities of the arm, shoulder, and hand score. So you want this to be lower. So this showed a better DASH score in the operated arm versus the non-operated arm. Now, since this paper has been published, there have been other publications that have refuted this claim, in particular that the functional outcomes are better. However, they do tend to still have similar outcomes in regards to malunion and non-union, which makes sense. But however, this landmark paper still spurred a change in philosophy of management of clavicle fractures. I think still is evident today. So it's often more considered than it used to be probably before this paper, even though we've self-corrected a bit. So what about the individual patient? What about your patient or yourself? Well, the absolute indication for surgery include open fractures or severe skin tenting, which is, for example, imminently open fractures. Also, subclavian arteries or veins is an absolute indication for surgery because surgical stabilization of the clavicle may be concurrent with a vascular repair. Relative indication for surgery include 2 centimeters of shortening, bilateral clavicle fractures, floating shoulder, which means that there's a concurrent shoulder blade or scapular fracture, or polytrauma, which is a patient with multiple injuries, for example, a concurrent leg injury where fixing the clavicle may aid their mobility. Brachial plexus injury is also a relative indication, as often even in non-operated on patients, nerve functions can return as it's partial injury, often. So what about how do you manage these patients? So if you go down the non-operative pathway, then the recommendation is a supportive sling, which means like a broad arm sling with elbow support. And a general recommendation would be that they start a gentle range of motion at 2 weeks, and they can progress to strengthening exercise at 6 weeks, at which time their sling can be discarded. If they go down an operative pathway, this usually includes plate fixation in the vast majority of cases, as you can see there. So that's the summary for middle clavicle fractures. Lateral clavicle fractures, almost a different condition altogether. It's the second most common type of clavicle fracture. It's also caused by direct trauma to the shoulder, similar to middle third clavicle fractures. On this presentation, I've put NIRS classification, and depending on the subtype, there can be up to half of the time, 56% of the time, there's a non-union. So this is one where you need to be a bit more careful. You may need to recognize that this is a condition that may require sort of further input or specialist input, and depending on the subtype, we may recommend surgical or non-surgical management. I don't expect anyone to really remember this, but I suppose my way of remembering it is that if there's no connection between the coracoid and the medial clavicle fragment, then they are at risk of non-union. So if there's so for example, type A, the type 2s, so type 2A and type 2B, and the type 5s are at risk of non-union, whereas the type 1s and 3s, where there's a CC ligament intact, are not so much at risk of non-union, and children, these physeal type injuries are also not as much of a risk of non-union. Lastly is medial clavicle fractures. So thankfully, medial clavicle fractures are extremely rare. They can be challenging to diagnose and manage, predominantly due to the close proximity of the great vessels to the area of injury. They often need a CT scan as pictured to further diagnose them often, even though there are described up-tilt views. The majority are minimally displaced, thankfully, and can be managed non-operatively. Displaced injuries may warrant further discussion with your surgeon. Well, thank you for your attention. We'll see you in the next video.